Okay, and can you hear me okay before I start babbling on?
Yes, we can hear you.
Okay, great. So, well, I'm Dr. Ali, Yousaf Ali, one of the rheumatologists here at Sinai. So thank you to the chiefs for inviting me, and I'm going to talk about gout and hyperuricemia, and this is to the interns, right? Is that correct? Okay.
Yes.
So I don't know if do we have a chat box here somewhere or not?
There should be at the bottom of Zoom, there's like a chat, and I can help in case anyone asks anything.
I was going to ask, maybe you can help, but the question I was going to ask, has anyone actually treated anyone with gout before? The interns, maybe you can put it in the chat box, or seen anyone with gout, and can you describe how
there's a consensus of yes.
Okay, good. Yes. Okay, I can see that. All right, good. All right, so that's good. So it's a very common disease. Let's see if I can forward my slides. Okay, so this has been around forever, first described by the Egyptians, and if you look at these mummies, you can actually, when they dig them up, they can actually see erosions in the first MTP joint. Hippocrates had gout and described this in 400 BC. And actually his description of gout was actually quite on the mark, because gout tends to be a disease of middle-aged men or a postmenopausal women. And even way back in 400 BC, he described gout never developing in men before puberty or in women before menopause, which is actually quite remarkable. And then in 1931, Sir Archibald Garrod, who actually was one of the fathers of inborn errors of metabolism, and he actually described alkaptonuria and homogentisic acid and so on. He actually described uric acid as the cause of gout when he actually observed the urate crystals in the joint. And I actually have a nice video of something similar to that. And then Dan McCarty also both visualized uric acid crystals and CPPD crystals with a polarized microscope. So if there's ever an issue with diagnosing gout and you have your rheumatologist nearby, see if you can tap the joint and actually look at the crystals yourself. And when we're on service, we'll do that from time to time. Now, if you remember, I'll talk a bit about hyperuricemia. So these are also the biochemical pathways we try our best to forget in biochemistry. But uric acid is derived from the degradation of DNA base pairs. So inosine, guanine is broken down to hypoxanthine and xanthine. And then in the human species, the final common pathway of DNA breakdown is actually uric acid. Now, uric acid is insoluble, so some of it's excreted and some of it is retained. And in animals, they have an enzyme called uricase, which basically dissolves uric acid to allantoin, and then that's further excreted. That's water soluble. It's excreted out. And then as you descend the chain of evolution, if you believe in evolution, you go down to fish and amphibians, and at the bottom of the ocean, you've got these marine invertebrates where they actually digest or metabolize uric acid to ammonia and CO2. So when you're on that first date and that bird poops on you, that white cheesy stuff is all uric acid being excreted. Not that it's ever happened to me or anything like that. Okay. So humans have deleted the uricase gene. So the question, of course, is why? Why do we not have why have we gotten rid of uricase? So why have we retained uric acid? And this has happened via various base pair codon deletions, millennia ago. And so we've actually held on to uric acid, unlike most mammals. So most mammals actually have a uric acid almost undetectable, less than 2 milligrams per deciliter. But humans and the great apes and New World monkeys actually don't have uricase. And so they have relative hyperuricemia. Now, the question, of course, is why, and we can only hypothesize on this. So if you look at our ancestors, there is fossil evidence from the Miocene era, 6 to 24 million years ago, where the theory was that our ancestors had this paleo-type diet. So they were sort of foraging around in the bushes of Africa or in the plains of Africa, and they had a diet that was very rich in berries and nuts, and occasional, you know, deer would go by or something. But basically it was a berry fruit type of diet. And it was a low sodium diet at that time. So the theory was that, I'm not sure how the anthropologists were able to figure this out, but the daily intake of sodium in our ancestors was estimated at 690 milligrams per day. Okay, now this is a question for your chat box. Does anyone know the daily amount of the daily intake of sodium in the Western diet currently? This is for John Andrilli. I'm making this interactive.
I'm not allowed to be called on, though.
Oh, sorry. The highly intelligent person fourth down on the screen. Wow, very good. So it's about 4 grams. 4 grams of sodium is the daily intake of sodium in the Western diet. Okay, so our ancestors had about 690 milligrams per day of sodium, which was a relative state of low sodium intake. And I won't use the term hyponatremia because that's incorrect, but they had a low sodium intake and they were in a state of relative low blood pressure as a result of that. Just trying to advance my slides here. So one of the concerns, one of the challenges with having a low sodium diet was a relative state of low blood pressure. And one of the challenges, of course, in terms of evolution of hunting was to be able to stand upright and maintain systolic blood pressure. So one of the theories was that actually we deleted the uricase gene, our serum uric acid level went up, and I'll show you in a couple of slides that uric acid can actually promote systolic blood pressure. So as we deleted uricase, urate went up, systolic blood pressure went up, and man or woman was allowed to stand upright and then hunt their prey and evolve as a result of that. All of this, I appreciate, makes the assumption that you believe in evolution. So if you don't, I apologize. So this is a slide of, this is a picture of a can of organic soup that I took from my pantry, from my larder. And here you can see this is organic, looks fairly healthy. But if you look at the sodium content of this in one serving, okay, it's 890 milligrams of sodium in one serving in a can of soup. Okay, now there are 2 servings per container. So you almost have 2 grams of sodium just in one can of soup now. So you can imagine now we have lost uricase, we have high uric acids, and we are in a state of sodium excess now, right? And so this is one of the concerns, that this is the evolution, the shape of things to come, because our diet has gone through the, our diet has changed and we've now become obese and we're in a sodium-rich environment. I will profess that I Googled this slide and I was looking up obese human with McDonald's, and I came across this slide, which is really depressing. Man tries to trade kidnapped baby for 15 Big Macs in McDonald's. This is a little aside from your boring days in medicine here. This guy, apparently, he kidnapped a baby and he went to McDonald's and he said, I want 15 Big Macs. And they said, how are you going to pay? And he said, I'll give you a baby. So this is completely unrelated to gout, so I apologize, but I couldn't resist showing you this slide. But it does make me worry about the future of the human species anyway. Okay, so we are hyperuricemic. So is there any benefit to being hyperuricemic? Because we reabsorb 90% of uric acid from the kidneys, from the tubules. And it may be that uric acid acts as a danger signal for the immune system. It actually helps with dendritic cells. It presents uric acid presented to APCs, antigen presenting cells, and actually can activate T cell response. And it has a powerful antioxidant effect as well. The other theory is that uric acid, because it has an antioxidant effect, may have a benefit in the brain. So it can stimulate the cerebral cortex. And there are some studies that show that in individuals with gout, they actually have a higher IQ. There's lots of confounders in those studies, including diet and alcohol and so on. So there may be some neuroprotective effects. So if you look at just the chemical structure of uric acid versus caffeine, it's actually quite similar, right? So uric acid may actually stimulate the brain in a similar way to caffeine. Again, uric acid may have neuroprotection. We know that there are lower levels in diseases of demyelination, such as multiple sclerosis, and also in Parkinson's disease as well. So the brain is very sensitive to oxygen consumption and oxidative stress. So if you have an antioxidant that's floating around, that could potentially protect you. This is a study, and thinking of the residents who are interested in doing studies from these hospital-based database that you guys have. This is an interesting study which was done in the UK from the THIN network, THIN, and they looked at, and if you're really serious about studies, look at these numbers. They looked at 59,000 gout patients. So this is a lot of work that they did. And they basically looked at the number of new cases of Alzheimer's in gout patients versus non-gout patients, and they adjusted them for all the usual confounders. And they found 309 cases of Alzheimer's in gout patients and almost 2,000 cases of Alzheimer's in individuals without gout. So it's an interesting observation. So 24% lower risk of Alzheimer's in patients with gout compared to controls. So again, potential genetic advantage to retaining uric acid. It's just another pictorial representation. So less Alzheimer's in gout patients. Now, this is what we traditionally think of, the bad, hyperuricemia. Obviously, gout is extremely painful. It can be incapacitating. Hypertension, I'm going to show you some mirroring data about how we can induce hypertension in a hyperuricemic model. Metabolic syndrome, again, this is controversial. Coronary artery disease. I have some studies currently looking at dual energy CT, where we've actually demonstrated the presence of uric acid within the coronary vessels, actually, and that's the first finding that's been described. We have another study looking at dissolution of urate to see if we can get rid of that. Vascular dementia, preeclampsia, chronic kidney disease. So as your GFR drops, your uric acid goes up. So potentially deleterious things. We know that uric acid can cause kidney stones as well. That's very painful. And it can deposit in soft tissues and hence tophi. So I think probably more bad than good, but anyhow. Uric acid is on the increase, and this is the serum levels of urate in the past century. This is from the NHANES database. There's an overall 44% increase in gout in the US. The last time this was reported was actually over a decade ago, so we're waiting for the latest data, but 44% increase of gout, but that's particularly increased in older folks. So in octogenarians, there's 114% increase in gout. And in men in general, almost 50% increase in gout. So why is this happening? You know, why is there more gout? People are living longer. There's more kidney disease, more diuretic use. Our diet has probably worsened. So going from more vegetables and fruit, we've gone to more purine-rich type foods. And there's more obesity as well. So one of the questions that comes up, and this is controversial, is hyperuricemia an independent risk factor for coronary disease? And the problem is that there's no consensus on this. There are some independent studies. There are some studies that show that it's an independent risk factor. And then there's a few that show, including Framingham, that it's not an independent risk factor for heart disease. So the verdict is still out. Now, I told you I would share some studies about uric acid in a murine model. And so we know that urate can in vitro activate the renin-angiotensin system. It can inhibit nitric oxide synthetase, and that results in smooth muscle proliferation. And it can also result in interstitial inflammation. So all of these things are deleterious, particularly in the kidney. And this is a study, and I apologize, it's a little busy here, but what they did is in a mouse model, or actually in a rat model, these investigators, they gave these rats something called oxalic acid. And oxalic acid is a natural inhibitor of uricase. And so what happens on the right graph, you can see the serum uric acid compared to the control group goes up, okay? Now, as the serum uric acid goes up, you get interstitial inflammation here. But also on the left, they measured blood pressure in these rats. And you can see there's a concomitant parallel increase in blood pressure as the serum urate goes up. So it's quite impressive. So hyperuricemia, hypertension in a rodent model. They then followed this up and they gave allopurinol to these mice, to these rats, and they found that the uric acid went down and the systolic blood pressure went down as well. So pretty interesting data showing that uric acid, at least in a rodent model, is associated with hypertension. So not only would it be important to treat hyperuricemia to treat gout and prevent gout, but maybe also to lower blood pressure as well. And there's, does anyone know of a antihypertensive that can lower uric acid? This might be on your boards if you had a choice. We know that thiazides and diuretics can increase uric acid, but do you know of any antihypertensives that can lower uric acid? I see.
Losartan or lisinopril.
I can see, ha ha ha. That's why you don't take food from Dr. Ali's larder. Sorry, I'm reading these backwards, sorry. Yes, losartan is the correct answer. So yeah, losartan is uric, so it helps promote uric acid excretion. So thinking in your Ryan clinic, if in your clinics, when you're seeing someone with gout and hypertension, if you can, try and give them losartan. So this is a study which is a very brave study where they looked at adolescents. They looked at 30 adolescents and they asked the question, what about in humans? Can you lower blood pressure if you give allopurinol, if you give uric acid lowering medication in humans, can you do that? Does it work? And so they looked at 30 adolescents and they gave placebo versus allopurinol, and they gave quite high doses, which was interesting. They measure systolic blood pressure and diastolic blood pressure, and we give this next graph, but on the right here, this is the allopurinol group, and it actually did show a slightly decreased incidence of blood pressure. So systolic blood pressure did come down in the allopurinol group compared to the placebo group. Now, this study has not been repeated, and it was from 2008. And one of the challenges is that allopurinol does have some rare potential side effects, including Stevens-Johnson syndrome. So it's not something that anyone's going to repeat in a hurry, given that you can use a thiazide. How about allopurinol and chronic kidney disease? So one of the things that comes up is, and the nephrologists push back on us a lot when we try and give allopurinol to patients with CKD, because the drug can accumulate and there's theoretical increased risk of side effects. And this is another interesting study where they took about 135 patients, they randomized 113, and these are patients with CKD, so they excluded anyone with a GFR over 60, and they said, okay, let's give them allopurinol versus a placebo. And what they found in this study, which is quite interesting, is that they found that when you give allopurinol, as you would expect, the uric acid declined, but interestingly, the GFR actually increased in these patients. So allopurinol was actually had a nephroprotection by lowering serum uric acid. So we actually will give allopurinol in our CKD patients, and we'll start at a low dose, but we'll increase the dose and titrate upwards. And it does have both a beneficial effect on the gout and lowering uric acid, but it also may increase GFR as well. So it's not all potentially toxic to the kidney. There is some data, again, this is inpatient analysis looking at allopurinol reducing overall cardiovascular complications and hospitalizations. Okay, so just looking at management strategies in hyperuricemia. So we know that there are a number of sources for uric acid. So exogenous purines, and that can be things that we eat, obviously, breakdown of DNA, endogenous purines. And then you have a urate body pool. And so when you thinking of decreasing uric acid, you can give dietary restriction, so you can change your diet. You can give xanthine oxidase inhibitors and inhibit the production of uric acid. Or you can give recombinant uricase, which is pegloticase or Krystexxa, and that increases sort of dissolution of uric acid. Or you can give a uricase or uric agent like probenecid, and that increases excretion of uric acid. These drugs have slightly fallen out of favor because when you give a drug that promotes uric acid excretion, then you can get renal stones that are urate stones that form in the kidney. So, but these are potential ways of getting rid of uric acid. So just again, thinking of diet. So the diet, in a patient with gout, diet contributes about 10% of the overall urate burden. About 90% is how your kidneys handle uric acid. And there are foods that promote gout, and there are foods that protect against gout. So alcohol is probably the top important food if you consider it a food. Beer is high in purine content. Then wine, then spirits rather, and then wine. So wine is the least nefarious, and then purine, so high purine diet. So anything like organs, like liver, kidneys, anything with a shell, so crustaceans, are all rich in purines. And then fructose as well is an important risk factor. And then high levels of caffeine. Caffeine can go on both sides. So low levels maybe protect against gout, and high levels maybe promote gout. Foods that also protect gout. I learned this from one of my patients, and since you're interns, when a patient says something to you that might sound crazy or unbelievable, just store it in the back of your mind, because often they may be right. And I had patients when I first went into practice that said to me, since I started eating cherries or tart cherry juice, I never got gout anymore. And I thought this cannot be true. And over the years, several patients told me that tart cherry juice actually inhibits their gout attacks. And since they've been drinking that, they never get gout. I've been desperately trying to get funding to do a study looking at tart cherry juice, but the makers of the tart cherry juice is a company called Cherry Farm, P-H-A-R-M. And they refuse to give me any funding. So if you have any contacts in that company, let me know. Or if you want to do this study, it's actually quite an interesting study to do, right? Tart cherry juice versus placebo in patients with gout, and let's see if it makes a difference. The problem is trying to get a placebo that looks and tastes like tart cherry juice, but is not tart cherry juice, because it has a thick consistency as well. Dairy may also be uric as a uric and promotes uric acid excretion. Now, fructose, as many of you know, is present in honey and fruit, and it's 50% of sugar. So sucrose is basically one glucose plus one fructose molecule. And with the history of sugar imported into the US via the slave trade, this has increased the amount of fructose in our diet. So, and also 55% of high fructose corn syrup is actually is fructose. So I'll just tell you a quick anecdote of a patient that I saw, and this is not quite a HIPAA violation, but this was one of many of Lady Gaga's managers. So that she has thousands of them. So that actually came to see us at Sinai a few years ago, and it's an interesting story. He at that time was quite an overweight middle-aged man, and he came in after flying. I think they'd just been on tour in Australia. He came into a urgent care in Manhattan with chest pain, and they told him he had costochondritis, so he'd been lifting heavy suitcases, and I guess his pain got worse. Came to the Sinai ER, where fortunately they investigated him, and he was found to have a large saddle embolus. He had a massive pulmonary embolus. And we got involved in rheumatology because after the surgeons and IR had fixed him up, he developed the worst gout I've seen for a long, long time. So severe polyarticular gout, multiple arthrocenteses, both knees, both ankles, wrists, giving him steroids. And he developed a little CKD from his pulmonary embolus. So we were sort of giving him we couldn't give him much colchicine or NSAIDs. But he really, in terms of risk factors, he was a young man, he was 38. We think of gout in middle-aged people or older folks or postmenopausal women. He really had no family history. Prior to his acute injury, didn't have any kidney dysfunction. And we went through these risk factors, and his one risk factor was that he drank 2 cans of soda every day. So for those of you that drink a lot of sugary drinks, this has been studied and is an independent risk factor for gout. Again, just appealing to the research component of your study and your training. This was a study done by Hyon Choi and his group at Boston University, where they looked prospectively. So this is a prospective study over 12 years. So those of you who are losing hope in your 6-week study, this guy and his team looked prospectively for 12 years at fructose consumption and the risk of gout. How about that for dedication, for research? And they looked at 46,000 men with no history of gout. I'm not sure why they just looked at men. Anyway, and they gave a validated food and soft drink questionnaire. They followed them up. And bottom line is that the relative risk of gout increased the more servings of fructose you had. And this is, I like pictures, so this is a pictorial representation, but 1 serving a day of high fructose sugary drink increased your risk of gout by 45%, but 2 or more increased your risk of gout by 85%. So if you, again, when you're counseling your gout patients, you should be telling them to really minimize the amount of sugary drinks and high fructose drinks. So that's an important thing. So I'll just talk briefly on hyperuricemia and the metabolic syndrome. And this is, again, one of the controversial areas. And, you know, we've been looking at this in our group, just looking at potential risk, cardiovascular risk factors. And so you guys know this better than me that, you know, looking at syndrome X or metabolic syndrome, there's prediabetes, central obesity with insulin resistance, dyslipidemia, hypertriglyceridemia, PCOS, hypertension, obviously, and then hyperuricemia, we think may be an additional risk factor for metabolic syndrome. So I think we're not at the point where we're treating hyperuricemia as a sole risk factor for metabolic syndrome, but that may evolve with time, actually. So just to keep an eye out for that. This is a reminder of the hyperuricemia cascade. So you've got dietary purines, you've got tissue nucleic acids, you've got endogenous purine synthesis, all resulting in uric acid. Remember that 90% of gout patients are renally under-excreting uric acid, so they're under-excreters of gout. Only 10% are overproducers. So overproducers, you think of patients with like psoriasis or an underlying malignancy, for instance. And these are the consequences on the bottom. So silent tissue deposition, so that's gouty tophi. Gout, that's the painful podagra. Renal manifestations, so again, you think of interstitial nephritis or kidney stones, and then potentially theoretically accelerated cardiovascular events. Again, this is an important slide. So uric acid crystallization occurs at higher levels in men than women. So crystallization occurs at about 6.8 milligrams per deciliter. Our serum goal, so this will be a board's question, you should be aiming for a serum uric acid at less than 6 milligrams per deciliter in your patients with recurrent gout. Okay, so if they ask you in your medicine boards or your in-service, what's the target for uric acid in a patient with recurrent gout, the answer is 6 milligrams per deciliter. Okay. And in patients who get recurrent gout, despite that, you can push it to even lower. In Europe, they actually recommend less than 5. So again, these are the risk factors I think you know about. So being male more than female, unless you're postmenopausal, living longer, having a diet rich in red meat, seafood, alcohol, diuretics. There are a bunch of other different medicines as well. So I remember the mnemonic CANT LEAP, C-A-N-T-L-E-A-P. So that's cyclosporin, low-dose aspirin. N is nicotinamide. T is thiazides. L is Lasix. E, ethambutol. A is alcohol. And P, pyrazinamide. So a lot of the old TB drugs that we don't use too much promote uric acid retention. Major organ transplantation, and I have to say we've seen some severe gout in the organ transplant patients, probably from a double whammy, particularly kidney transplants, because they take cyclosporin or macrolides, number 1, and number 2, they have low GFR. End-stage renal disease, and these folks also are challenging to treat because of their kidneys. You cannot use NSAIDs. We end up often using a lot of steroids in them. And then there are some genetic reasons, so things that you don't see very often, such as HGPRT deficiency, Lesch-Nyhan syndrome, can predispose to gout as well. So now, often we'll see patients who have no clinical symptoms of gout, and they're on colchicine monotherapy. So they just take colchicine 0.6 milligrams a day, or 0.6 BID, and they never get gout, right? Because colchicine prevents microtubule migration of leukocytes to the point of the urate crystals, but they get unhindered chronic hyperuricemia, and the uric acid deposits in the kidneys and it deposits in the skin. So this is what you see. So you see patients with severe deposition of urate, and this is, so when you're thinking to yourself, well, it's just gout, so what? This is what can happen, and we do see this from time to time. If you see this kind of picture where you have this caseous discharge, it looks like almost like a septic digit, right? This looks like this could be cellulitis or a septic arthritis in that PIP joint. It's red, it's angry, it's tender, but the difference is that it's exuding this caseous type material. Now, if you take a slide, and sorry, I'm going to sneeze there. If you take a slide and you smear it on a slide, you'll see these uric acid crystals. And you can save the patient admission and 2 weeks of IV antibiotics and all that sort of stuff. So if you're thinking that the patient could have gout, this would be one to talk to your rheumatology colleagues about, and just look at this under a peripheral smear. Now, can anyone tell me what this is called? What's this? If you had to give a description of what you're seeing right now, you put this in the chat box. What would this, how would you describe this finding? Don't say arthritis, although it could be arthritis. The correct terminology for this, it begins with D. So this is dactylitis, very good, with a Y. So dactylitis, good, excellent. And do you know what diseases give you dactylitis? Anyone? See if I can look in the, very good, yeah. So sickle cell in kids, outstanding. Psoriasis and spondyloarthropathies, very good, outstanding. So that's good. So dactylitis is basically an inflammation. It's like an enthesopathy. So it's where the tendon inserts into the joint, and it's really the hallmark of a spondyloarthropathy, such as psoriatic arthritis. So when you see this kind of digit, obviously think of infection, but think of spondyloarthropathy and look for things like pitting of the nails, which you can see. This increases the risk of psoriatic arthritis. When you see patients with psoriatic arthritis, don't forget to look in other areas. So psoriasis tends to occur where the sun doesn't shine. So under the breasts, in the navel, periumbilical region, in the gluteal cleft, and in the scalp as well. So these are common areas where psoriasis happens. I will see patients from time to time with recurrent dactylitis, and many of them have cycled through orthopedics or primary care, and no one's put everything together, and then you give them NSAIDs and it partially responds, and then you look in their scalp or you look in their belly button, you see psoriasis, and those folks actually often end up needing a biologic, so they need Humira or etanercept. Now this is just a slide that shows, this is a slide that shows who's treating gout, and this is a very depressing slide, because if you look at who's treating gout, primary care, obviously that makes sense and that's appropriate, but cardiologists probably treat more gout than rheumatologists, which I find really depressing. No disrespect to my cardiology colleagues, but I think they'd be horrified if they saw that rheumatologists were treating all the MIs compared to them. And I think this is just because this is where the patients live, right? Someone comes in with a hot joint, they go to the ER, they go to orthopedic surgery, or they go to the primary care doc. But because cardiologists give a lot of diuretics, I think they induce a lot of gout, and so the patients will call them back. So let's see if this will work. This is a YouTube. So one of the things that comes up, actually, let me put this in the chat question. So how long do you think it takes for gout to resolve by itself? Anyone have any ideas? like a day, 2 days, a week, 10 days, a month? Let's assume that you treat it with colchicine. I can see Bruno Costa, 3 days. Sam Cheng, 3, 1 to 2. Okay, well, you guys are very optimistic. Or you're very good doctors. So gout untreated can actually go as long as 10 days. If you treat it, it can be 3 to 5 days, but it's not unusual that you'll get a gouty attack that can last like a week. And I want to just show you. And so when a patient calls you like a week into their gout attack, I want you to remember this video, see if this will work. These are your macrophages phagocytosing the needle uric acid crystals, and just see how they're being eaten up. It's such a really impressive picture. I thought I liked this when I saw this. And so this is your immune system at play here, phagocytosing the uric crystals. You like that? Okay. Let's see if I can get out of this. So that's why it can take a while for gout to. That's why it takes a while for gout to resolve, because that whole process can take a long time. There was a rheumatologist, one of my old bosses in New Haven a few years ago, and he did this radio labeling of leukocytes. And in his study, he actually showed that up to 1 million white cells will enter an acute gouty joint in 1 hour. Intense inflammation. So gout is extremely painful. It's one of those things you really want to treat. Now, sometimes it can be difficult to diagnose. So the gold standard diagnosis of gout is arthrocentesis of fresh synovial fluid. So if someone comes in with a hot joint, like a big toe that's inflamed or a wrist, you really want to try and tap the joint and look for synovial fluid and look under the polarized microscope. Now, sometimes that's not possible because it's a big joint or there's another reason for that. So you can use something called dual energy CT, and this is a imaging technique where you actually zap the patient with 2 photon beams of different energy, and urate has a specific signal, and it actually looks as this green signal that shows. So this is all tophaceous material. So this is called dual energy CT, and you can see urate is actually everywhere. It can occur in the spine. Michael Pillinger at NYU has shown, he's got some nice study looking at urate that lights up in the spine. So it can maybe even be an unusual cause of low back pain, gouty deposits. We touched on this briefly, so multiple different medications. These are uricosuric medications that promote urate excretion. So probenecid, for instance, losartan. Generally, we use allopurinol as the first-line therapy because it's cheap, it's effective, been around for 50 years. And then this is pegloticase, and so this is Cristexa. This is an amazing molecule that's given intravenously every 2 weeks. And this is, if you think back to my first few slides where I showed you that mammals and other species have uricase, which dissolves uric acid. And they have uric acids of less than 2. So if I give a patient with a uric acid of 10 or 12 milligrams per deciliter, if I give them allopurinol, I can lower uric acid from 12 or 10 to maybe 8 in about 6 months. If you look here, if you give pegloticase, you can lower uric acid to less than 2 in 72 hours, which again just shows what a flawed species the humans are compared to animals, you know. So it's amazing, right? It's an incredible drug. IV uric acid, 8 to less than 2 in 72 hours. The problem is it's very expensive. It costs about $60,000. So it's an expensive drug to give. I think you guys use this in tumor lysis syndrome, something similar, right? One of these rasburicase or something. Anjed, what do you guys use? Something similar, right? To prevent tumor lysis. So it's a very effective drug. We will use this in patients with tophaceous gout from time to time. So I want to just spend, I think, how long do I have? 5 minutes, right? A few minutes left. So I'm going to just spend the last few slides just going through the American College of Rheumatology guidelines for the management of gout, okay? So initiating urate lowering therapy, ULT, is strongly recommended for gout patients with, if they have tophi, so greater than 1 tophi, if they have X-ray damage. So if you X-ray the patient's joint and they have erosions, if they have joint damage that we attribute to gout, then we should give them allopurinol. If they are having frequent gout attacks, so more than 2 a year attacks, they should be on allopurinol. So if you're in your Ryan Center and someone keeps getting gouty attacks, keeps going to the emergency room, or you see them on the inpatient ward and they come in with gout, you should be thinking, why is this person not taking allopurinol? Why are they not on urate lowering therapy? So we recommend that for people with recurrent gout. So if you have just 1 attack and it's your first attack, we don't recommend it because there's a percentage of folks that. Can you hear that?
Yes.
Is that might be my YouTube.
Oh, yeah, it is.
How do I get out of that?
Let me just close the window.
Close the window.
That one up there?
No. Like
Oh,
the
shit.
one.
Sorry. Shit. Hang on, let me just
Oh,
go
it's
back.
embarrassing when the old attending doesn't know how to use his computer, right?
Middle-aged, thank you.
Middle-aged, yes.
Hang on, let me find my. That's your fault because you told me to close out of it. That's me not taking any responsibility. Hang on. Sorry.
Should never show your email screen.
I know. Scary. I was going to the last few slides here.
He's a Google slide person too. That tells you something about his personality.
Okay, I just want to go through some of these things here. Okay, recommendations. So, see, I can't even, how do I make this big screen again?
I'm not sure if you can do it from this.
Okay, all right, can you see this?
Yeah.
Okay, sorry about that. So recommendations for initial choice of urate lowering therapy. So basically allopurinol is the first line recommended therapy. Allopurinol is 3 cents a pill. Uric, which is febuxostat, is $3 a pill. So it's a lot more expensive. There are no allopurinol pharmaceutical reps. There are tons of pharmaceutical reps for Uric, and there's advertising. And so there's a lot of penetration in the primary care world of Uric, but it's really not much better, and it's a lot more expensive. So you should be starting allopurinol in general. We do not recommend pegloticase, despite what the pharmaceutical reps, again, may tell you, for first-line therapy. And then we should be, so when you start allopurinol, when you start these drugs, what happens is that you lower uric acid, which is the point. And when urate is dropped suddenly, it can actually trigger gout. So we often give prophylactic concomitant anti-inflammatory therapies such as colchicine or NSAIDs, usually for the first 3 to 6 months. So if you're going to start allopurinol, you want to give it with colchicine or allopurinol for the first 6 months. Okay. Recommendations for patients receiving ULT. So allopurinol, you may have heard of, has anyone heard of this gene HLA-B5801? So it's a gene that it's a gene that is that can predispose to this allopurinol hypersensitivity, particularly found in patients, Han Chinese and people of Thai descent, Southeast Asian descent, and some African American patients as well. So if you are seeing individuals with that background, you should be checking that gene before you start the drug, so if possible. And then we generally recommend starting at lower doses of allopurinol, so 100 milligrams or so, as opposed to 300 milligrams. And then you can titrate up. Remember, the goal of uric acid should be less than 6 milligrams. If you if the patient does not reach target, so if you cannot get them to a urate of less than 6, you can switch them to a different agent such as febuxostat as opposed to adding like something like probenecid. And you would change uric acid lowering strategy or change therapy if you cannot get them below 6. And you would think about pegloticase for people that get recurrent gout attacks if they have huge tophi and you cannot manage them. So just a bit about inpatient management of gout. So this is for the residents, for the interns, for you guys, because you'll manage this. You'll see this in the inpatient world. So if someone comes in with podagra, they have a hot red joint, they're active, they're miserable, you can give colchicine, and we usually give, does anyone remember what the dose of colchicine is for the first attack? So let's say you're the admitting resident or the admitting intern, and they come in, the patient's got a hot red swollen knee or a swollen toe. Good. Okay, good, interesting. All right, so I'm seeing a few different doses until diarrhea starts, 1.8, 0.5. Okay, so generally what we do is we give 1.2 milligrams. It comes in 0.6 milligrams. So we give 1.2 milligrams at the time of the attack. So that's two tablets at the time of the attack, and then 0.6 milligrams 1 hour later, and that's it. Now, when I was in training, we used to give 0.6 every hour until diarrhea occurs or until resolution occurs. But the problem with that is that people get toxicity and not everyone gets diarrhea. So there are reports of people getting it round the clock and getting severe side effects from that. So 1.2 milligrams, 0.6 1 hour later, or you can give high-dose NSAIDs, that's 50 milligrams of indomethacin TID, or 800 of ibuprofen like TID, but that's almost none of our patients because everyone's got CKD. If the patient has kidney dysfunction, you can give prednisone or intra-articular steroid, assuming that they don't have a septic joint. So if you think that you're happy that you tap the joint, there's no infection in there, and let's say they have a creatinine of 3 or 4, you are nervous about using colchicine, you can, and the cultures are negative, you can give intra-articular steroid in those patients. In some patients, you can give an interleukin-1 antagonist, that's anakinra or Kineret. Again, very expensive. We use that drug for Still's disease. And if you can get it, we've given it to some inpatients, but it's been challenging to get hold of. Okay, and then just my final slide. So hyperuricemia is relatively confined to the human species. Uric acids may protect the CNS and decrease the risk of dementia and multiple sclerosis. Hyperuricemia is associated with hypertension in rats and in adolescents. Normalization of serum uric acid is good not only to prevent gout, and your goal should be a target of less than 6, but it may also be nephroprotective, so it may actually protect the kidneys. And I'll just throw these out there. These are sort of questions for discussion amongst yourselves in your free time. I know you'd like to discuss this. Should we be treating asymptomatic hyperuricemia? And that may change in the future. And should we be monitoring uric acid in patients at risk for coronary disease without gout, right? So if you're a 48-year-old middle-aged, male or female, and you have a strong family history of gout, maybe a strong family history of heart disease, but you don't have anything else, and you have no other risk factors, should we, in addition to lipids and blood pressure and smoking and cholesterol, should we be checking uric acid as well? So that's sort of an evolving target. We don't know at this point, but I'm hoping some of our research will delineate that. So I'm going to stop there. So maybe I'll pass it back to your chiefs, and happy to take any questions. Thank you for your attention virtually.
Thank you. That's really great lecture. Does anyone have any questions, comments? You can unmute yourself already in the chat.
This is the bit where in real time, people would throw shoes at the speaker and that kind of stuff, throw an apple or a banana or something. So everything you need to know about gout, hopefully.